industries. I know we've been around forever, but we're beginning to get more, I'd say, almost industrialized and fit more of the models that other industries have gone through. But bottom line is, falling revenues and expense pressures that we're seeing are causing, to some degree, some consolidations to take place. Here's another interesting fact. This came out in Forbes this year. It looked at the profitability of various industries, and I thought it was interesting to see that we kind of down there in the bottom in the healthcare services area, the clinics, the hospitals, things like that. You know, you're seeing somewhere in the, I'd say, the 1 to 4% range, maybe a little bit higher, certainly in some of the more profitable regions that are out there based on payer mix, but a relatively low margin. But when we look at healthcare technology, it's tremendous. So one of the issues that we have is there's a couple things come out. We have to be just conscious of this disparity between the very low and the very high margins that are out there. So one of the things that we need to do as providers is be able to have almost comparative analytics or comparative effectiveness to make sure that every dollar we're spending truly counts. And I personally believe that big data and analytics will help lead us to understanding much, much more about every dollar we're spending, is it really counting? Next up is, so why is it important? It's important because it's important to all of our leaders in healthcare today. And this was a study by HFMA last year that I thought was very interesting, because it says, you know, please rate the following capabilities and importance in 3 years. Interoperability, that implies systems talking to each other, real-time data access, and business intelligence. The top 3 items on the list. When we take the next list over, it's how could the following impact your organization's ability to accept risk in a value-based contract. We believe that there will be a continued progression towards more risk management that we will have to take on as organizations. Well, if we take a look at what the top 3 here are: analytics support, BI, consistent measures for quality. We have to be able to defend our position on quality, and then patient-level monitoring and regime adherence. So all of this is around, I need access to monitors, sensors, understanding of where I stand today, and understand what works. So, you know, just this is more piling on, but all of this just goes to point to where if we're going to be leaders in healthcare, if we're going to be selling to providers in healthcare, these are things that I have to be able to converse with my customers or my leadership in the organizations, and I have to be ahead of the game, or else it's going to run over me. So as we take a look at supply chain, you know, one of the things that I think there's 3 fundamental flows we all have to have our minds around. And those 3 fundamental flows are around funds, products, and information. In supply chain, we've tended to focus a great deal of our time on funds and products. You know, give me a great price, let's get great terms and conditions out there from a funds perspective, and then let's source those products in the most productive ways to bring it through our systems. But we've now got to the same rigor and the same attention that we spend in those 2, we're going to have to move into the information side. We have to understand all of the different information around the production, around the performance of those products and services that we're acquiring from the market. Next up, so this, I thought this was just kind of interesting. So, you know, why is big data analytics so important to you? This was an old chart from Gartner that I looked at, and it just shows you from, you know, back in June of 2011, it was almost unheard of. If you did a Google on number of searches in this particular area, it was almost, I mean, big data analytics was no big deal. But you can see the ramp up, and so I just took a look at Google references for various different items, and I did this on New Year's Eve. Tells you just how sad my life is, but bottom line, I took a look at this and said, okay, if you type in NCAA championship, it's coming into the pre-bowl games there, and it had 111 million searchable documents on Google for that particular topic. Supply chain management. Good news is we actually were on that date we're a little bit more important than the NCAA championships. That's great. Donald Trump was a little bit higher than all of us there. Healthcare steps up even about 2x plus on Donald Trump. But when you get into big data and analytics, truly it explodes. And I was amazed at how many things, I tried to find things that were topical in that very moment in time, and yet big data and analytics blew everybody else away. So the world is looking at this. We need to be well versed in this. This is a reference. This was a Harvard Business Review article. It's a cover story around big data, and you know, it was a good descriptive article, and it really highlighted what defines big data. And as we look at big data, there's several definitions of it. I like this one around variety, volume, and velocity. And the variety, we certainly have variety in healthcare. It's coming from every place. When we have tended to computerize our information, we have volumes and volumes of information that sits out there in a vault somewhere. So you've got the volume and the variety in healthcare. The thing that's coming is around the velocity. Much of our world has been batched. We'll collect the information, we'll store it in a database, and then when we need it, we'll go get it in a batch and we'll process it. Well, we're having real-time transactions now taking place in our world, and I believe that's going to be the biggest thing that we're going to deal with in the future. Real-time transactions, the velocity is truly going to challenge us in the future. As we take a look at it, this is for me just, it's descriptive for me. You know, as I look at data, information, and insight, those are the three elements I think that are closest or near and dearest to my heart. When I look at data, data is basically tables. It's not necessarily usable. It's just information, or I should say, it's just data. When we take that data and convert it into something that it provides you a little bit more information, it's got context to it, then all of a sudden it begins to reveal itself. But the real value to me in the future is going to be around the insight piece. And as you see the diagram there at the bottom that shows a hurricane coming up the east coast of the U.S., looking at predicted paths and probabilities and things like that, I believe this is the world we're going to live in the future. You've got to get your data right and clean. You've got to convert that into information and use that information to provide you some guidance, but ultimately we'll be moving into that predictive world in the future. This was another interesting study. This was out of Forbes Insight 2015, and it was just going on. It was looked at multiple industries, and it took a look at them. About 90% of the organizations report that, you know, this is a big deal, and so we need to get our heads around this, because these were CEOs, CFOs, and COOs that took this study of all industries. And so this is once again, if it's important in the boardroom, if it's important in the C-suites, it's important to us. This was something else I thought was important. Every year, Gartner in July comes out with the Gartner Hype Curve, and I like it because it talks about all those things that everybody's talking about, and where exactly does it fit on the curve? Is it emerging? Is it coming up? Is it at its peak? It's got its complete volume on it, or is it beginning to descend? You're starting to see winners and losers, and it's moving into actual use. And what we're seeing today at the very peak, we're seeing advanced analytics, and we're looking at the Internet of Things. Those two things I think come together, and I'll show you in a second how they kind of come together. But these are things, once again, the world's talking about it. It is important. If we're going to be relevant in the industry today, we better be relevant. We better have relevant knowledge of it and how it applies to our industry. Next up, this is more on the Forbes Insight report, and this is somewhat almost disturbing to me. So I took a look at it. You know, once again, all of the information at the very top of the screen comes up and said, you know, the impact of business on big data. 75% of respondents said it's transformative in nature. That's pretty compelling to me, that something of that large a magnitude. But when we look at the industry comparison, we find that, you know what, healthcare is lagging significantly, especially in the areas of retail and telecom and some of the others. So this just tells me that, you know what, we've got a ton of data, but we haven't realized the value that other industries have. And we got to get our heads around this, because it's going to be something that I think will differentiate. It will help us pick winners and losers. Those people who can use information will be able to respond much more quickly and also be more credible in the delivery of their offerings. Now, when we look at healthcare, once again, this is kind of the last setup slide, I believe, and it really starts talking about 16,000 hospitals, 4.9 million patients out there. We have all types of monitors that are now coming forward, wearables, things like that. So we're about to be overcome in ways that, in an accelerating way, to where we think we have a ton of data today. We're just scratching the surface of what we'll probably see in the next 3 to 5 years. So this is just setting the stage for where we'll be in the not so distant future. Now, what I'm going to do, the presentation's been put together. There's really 3 or 4 videos that I'm going to show you here. And the videos are I think they're very compelling. They tell a story much better than I can. The first one is around the Internet of Things. And this is a TED Talks video that I saw about a year ago that was so compelling around taking information or taking technology that's being used in other industries and bringing it forward in healthcare to truly make an impact. So if you don't mind, let's go ahead and go into this now. Hopefully the audio will work well for us. Just a very compelling argument for thinking beyond the box.
Motor racing is a funny old business. We make a new car every year, and then we spend the rest of the season trying to understand what it is we built. to make it better, to make it faster. And then the next year, we start again. Now, the car you see in front of you is quite complicated. The chassis is made up of about 11,000 components, the engine, another 6,000, electronics, about 8,500. So there's about 25,000 things there that can go wrong. So motor racing is very much about attention to detail. The other thing about Formula One in particular is we're always changing the car. We're always trying to make it faster. So every 2 weeks, we will be making about 5,000 new components to fit to the car. 5 to 10% of the race car will be different every 2 weeks of the year. So how do we do that? Well, we start our life with the racing car. We have a lot of sensors on the car to measure things. On the race car in front of you here, there are about 120 sensors when it goes into a race. It's measuring all sorts of things around the car. That data is logged. We're logging about 500 different parameters within the data systems, about 13,000 health parameters and events to say when things are not working the way they should do. And we're sending that data back to the garage using telemetry at a rate of 2 to 4 megabits per second. So during a 2-hour race, each car will be sending 750 million numbers. That's twice as many numbers as words that each of us speaks in our lifetime. It's a huge amount of data. But it's not enough just to have data and measure it. You need to be able to do something with it. So we spend a lot of time and effort in turning the data into stories to be able to tell what's the state of the engine, how are the tires degrading, what's the situation with fuel consumption. So all of this is taking data, turning it into knowledge that we can act upon. Okay, so let's have a look at a little bit of data. But let's pick a bit of data from another 3-month-old patient. This is a child. And what you're seeing here is real data. And on the far right-hand side, where everything starts getting a little bit catastrophic, that is the patient going into cardiac arrest. It was deemed to be an unpredictable event. This was a heart attack that no one could see coming. But when we look at the information there, we can see that things are starting to become a little fuzzy about 5 minutes or so before the cardiac arrest. We can see small changes in things like the heart rate moving. These are all undetected by normal thresholds which would be applied to data. So the question is, why couldn't we see it? Was this a predictable event? Can we look more at the patterns in the data to be able to do things better? So this is a child about the same age as the racing car on stage, 3 months old. It's a patient with a heart problem. Now, when you look at some of the data on the screen above, things like heart rate, pulse oxygen, respiration rates, they're all unusual for a normal child, but they're quite normal for the child there. And so one of the challenges you have in healthcare is how can I look at the patient in front of me, have something which is specific for her, and be able to detect when things start to change, when things start to deteriorate. Because like a racing car, any patient, when things start to go bad, you have a short time to make a difference. So what we did is we took a data system, which we run every 2 weeks of the year in Formula One, and we installed it on the hospital computers at Birmingham Children's Hospital. We streamed data from the bedside instruments in their pediatric intensive care so that we could both look at the data in real time and, more importantly, to store the data so that we could start to learn from it. And then we applied an application on top which would allow us to tease out the patterns in the data in real time so we could see what was happening, so we could determine when things started to change. Now, in motor racing, we're all a little bit ambitious, audacious, a little bit arrogant sometimes. So we decided we would also look at the children as they were being transported to intensive care. Why should we wait until they arrived in the hospital before we started to look? And so we installed a real-time link between the ambulance and the hospital, just using normal 3G telephony. to send that data so that the ambulance became an extra bed in intensive care. And then we started looking at the data. So the wiggly lines at the top, all the colors, this is the normal sort of data you would see on a monitor: heart rate, pulse, oxygen within the blood, and respiration. The lines on the bottom, the blue and the red, these are the interesting ones. The red line is showing an automated version of the early warning score that Birmingham Children's Hospital were already running. They've been running that since 2008 and already have stopped cardiac arrests and distress within the hospital. The blue line is an indication of when patterns start to change. And immediately, before we even started putting in clinical interpretation, we can see that the data is speaking to us. It's telling us that something is going wrong. The plot with the red and the green blobs, this is plotting different components of the data against each other. The green is us learning what is normal for that child. We call it the cloud of normality. And when things start to change, when conditions start to deteriorate, we move into the red line. There's no rocket science here. It is displaying data that exists already in a different way to amplify it, to provide cues to the doctors, to the nurses, so they can see what's happening. In the same way that a good racing driver relies on cues to decide when to apply the brakes, when to turn into a corner, we need to help our physicians and our nurses to see when things are starting to go wrong. So we have a very ambitious program. We think that there is the race is on to do something differently. We are thinking big. It's the right thing to do. We have an approach which, if it's successful, there's no reason why it should stay within a hospital. It can go beyond the walls. With wireless connectivity these days, there is no reason why patients, doctors, and nurses always have to be in the same place at the same time. And meanwhile, we'll take our little 3-month-old baby, keep taking it to the track, keeping it safe, and making it faster and better. Thank you very much.
Okay, so to me, this was very compelling. It kind of told me we've got to think and act a little bit differently because we collect information all day long. We're seeing monsters all day long, but this takes and applies a completely different type of science. So this is just something that was so compelling to me from the beginning. It also is a little foreshadowing. You'll get into, a little bit later, we'll get into the continuum of care that talks about virtual care. And we believe, just as was mentioned there at the end, that in the future, we will be able to do things remotely that we just can't do or haven't been able to do heretofore. So really, let's kind of shift gears. Let's get into the next area, and this really gets into the level of business intelligence maturity. I love the descriptive, predictive, and prescriptive analytics. I believe, when we talk about that around here, we have been, for the most part, focused for so long in the descriptive area, and I would say even that piece is maturing. I'll show you that in a second. We're also going to get into a couple applications that I'm going to share with you around the predictive nature and how that can lead to better outcomes, but ultimately getting to the point to where that information that was descriptive has now been used to predict the future. And once we predict the future with great confidence, we can be prescriptive in nature and how we would make recommendations to our clinical caregivers or operational support personnel. So that's kind of a setup for the next section. So in this, we have descriptive analytics. We've spent, I'd say, for the last couple of years, this is an area that's pretty mature at Mercy. We've created a descriptive analytics dashboard for several different areas. It reports across the entire ministry, and our ability to look at our response times, the MTS resource management, that's our IT group. They have a complete dashboard on how well they're responding to the needs of their customers. We also have clinical pathway utilization for the various pathways that we have out there. But still, these are very descriptive in nature. They do have trends on them and things like that, either both up and down, that we can have conversations on how are we doing or what do we need to improve on. But this is something that we built, and we think it's very important. We built it into our internet page, so it's always on. It's always the most up-to-date information, so no more do we have to worry about, hey, can you send me that report? We just say, go to the dashboard. I have the same information you do. So this has been something that's been very helpful in generating the right types of conversations, and we don't have competing data wars now that we once had because it's right there in front of us. And once again, it's credible, it's always online, and it's always the most up-to-date that we have. Next up, though, is we said really in healthcare, this is an oversimplification of what we do for a living, but bottom line, at the end of the day, you know, the industry and we have needs, wants, and desires, but it breaks down into really two things. We need three things. We need great patient outcomes. We need a positive bottom line so we can keep our doors open. And then we need a great experience. And the great experience is not only for our patients so that they will feel well supported, well treated, but we also need to create an environment for our coworkers. And so we think those go hand in hand as well. So that's kind of the filters that everything goes through: clinical, operational, and financial. But when you distill that down, what's the real work is to understand and provide the best care, and to do so with the least amount of resources. Now, the understand and provide the best care side. Now, that really, to us, we've kind of named that care paths. We're developing care paths that will be based in science, and then if we understand those care paths, we should be able to build operating paths that will support that care. And that's to do so with the least amount of resources. So that's kind of a fundamental concept that we will have throughout the rest. First of all, the understand and provide the best. Well, this deals with a little bit of, you know, 4 key elements: population health, who has what condition and needs what type of treatment, clinical pathways, what's the right thing to do, let's learn from ourselves and learn from others. We think that's important to collaborate on these. And then finally, the quality outcomes, how do we perform, and then based on how we perform, let's look at variation and then be able to make adjustments from that. Our general beliefs: we've got the information, we have the tools, we just need to put it together in a productive way so that it can yield much better outcomes in the future. So what we did is we reached out. We knew that we needed help in this. We reached out to a firm out in California in the Silicon Valley area that actually helped us understand that all data has patterns. All information is connected in a way that those patterns can help us see things that we couldn't normally see before. And we'll hit a video here in a second, but we ran really just 3 areas. We did lumbar, total knee, and lap chole, and we sent large bulk bits of data to them, and they then processed it and came up with somewhere between 5 and 15% savings and length of stay opportunities in these various areas. Now, the interesting thing is in the total knee, we had just completed a manual process by which we created a care path. We thought we were pretty good, and we still found 5% opportunity in this particular area. So when we take this information, we extrapolate it across all of our procedures in Mercy. This is just a portion of our care, of course, but it highlighted that there's a potential. Once again, it's just potential, but a potential for $110 million worth of improvement opportunity, while at the same time improving care. So you got the financial side, we got to keep our doors open, but this also gives us great insight into what works and what doesn't. So up next, this is a little bit on the firm. Yasi Care is the name of the product that we use in this particular case, and we did some joint development with the ISD on this. So let me go ahead and roll this, and it'll be pretty self-explanatory.
The future of healthcare lies within our data. Within that data, obscured by complexity, lie the answers that policymakers, healthcare administrators, doctors, nurses, and patients all seek: better care and lower costs. It all starts with data. Millions and millions of data points from EMR systems, billing systems, and other patient records. It starts with understanding the shape of data. By understanding the shape of data, we can quickly find the relevant patterns in the data, and in doing so, reveal the optimal way to perform any surgical procedure, while simultaneously determining what drugs, tests, implants, and other products contribute to that optimal outcome. Until now, due to complexity, marketing has led science. With technologies such as ours, science will lead marketing. They say a picture is worth 1,000 words. This one was worth $50 million for Mercy. It is the cornerstone of a clinical pathways initiative that is impacting everything from how patients are treated to how drugs, devices, and even doctors are measured. This specific picture represents thousands of patients who had total knee replacement surgeries at Mercy. At first glance, it may be difficult to discern how the millions of data points are organized. Soon, however, the viewer recognizes that it is organized by shape. Shape tells us that the patients naturally divide into clusters or groups of patients with similar outcomes. Of interest to us is the length of stay. The length of stay is the primary quality metric for total knee replacement surgery, because the faster you walk, the faster you recover, and the faster you walk out of the hospital. Here we find good outcomes grouped together in blue, and suboptimal outcomes grouped together. While one can explore this data manually, quickly finding patterns, understanding why those patterns exist, and what the drivers of those patterns are, Mercy wanted to source that information in such a way that it could be consumed broadly across the organization, from doctors and nurses all the way through to purchasing managers. Enter IOSD Care. Developed with Mercy's input over a 9-month period, IOSD Care eliminates the complexity while presenting the outcomes that matter in a more intuitive manner. For example, what can the shape we saw in the data a moment ago tell us about the optimal pathway for total knee replacement surgery? And more importantly, what procedures or products differentiate that pathway from other potential pathways? IOSD Care automatically generates the outcome groups that you saw earlier as clusters of patients, now represented as cards, containing clinically relevant information, such as how many patients are in each group, how long did they stay, what was the average cost. There are a half dozen groups, but let's concentrate on the one with the lowest length of stay, which we have already established as the best quality metric. Here we see all the underlying data in a longitudinal view. Every row is a patient. Every hash mark, an interaction with the provider, a lab, a scalpel, a drug. At the top in blue, we show the computed care path of this group. The computed care path is the exact sequence of steps required to produce the shortest length of stay. On the right, we can see every relevant detail about the recommended treatment steps, when they should happen, what they cost, and so on. In the past, it would take a team of doctors 9 to 12 months to come up with this level of granularity, and it would be obsolete by the time they started to debate the recommendations. Software can do it in seconds, without bias. Software learns from every new knee surgery, not just the ones an individual doctor performs. Software also tells us what differentiates this treatment from other possible ones. The ability to source what differentiates good outcomes from poor ones is incredibly powerful for doctors and administrators alike. A perfect example is right here in orange. One of the differentiators in this, the best outcome, is the administration of pregabalin. It was being performed by a small group of doctors less than 100 miles from Mercy's headquarters. They were administering this drug, generally prescribed for shingles, prior to surgery. These doctors had seen something in the literature that led them to believe that pregabalin would inhibit postoperative pain, reducing opiate usage and resulting in faster ambulation. It did. More importantly, Mercy never would have discovered this innovation using traditional approaches. Why? Because they never would have asked the question, what if we use a shingles drug for total knee replacement? But here it is, in Mercy's backyard, and it was undeniably a best practice. Each of the best outcomes includes it, marked with a dot. Look at how prevalent it is. Millions of data points tell us that this is the optimal surgical sequence. And with a single click, you can publish a care path, a task that took man years to create previously. So now we are in our care path view. As you can see, we have a simple calendar-like presentation of the order set of interest, which we can edit as necessary. Designed for doctors, this is also a powerful what-if tool for administrators. What if I swapped out this expensive drug with a generic version? What if I replaced the existing knee with this newer, more expensive model? Is it a justifiable upgrade? Each change results in a new outcome. Again, using data generated daily by the hospital. Think about that for a second. Every event, every action that is captured in the billing and EMR system is now available to an administrator. This approach exposes what devices, drugs, implants, and labs are meaningful and which are not. Mercy developed another care path, the laparoscopic cholecystectomy, and in doing so, they created a series of groups of outstanding outcomes. While the outcomes were the same, the cost associated with those outcomes was not. The difference was, on average, around $500 per procedure. The primary reason for that difference? The clip used. One clip cost 2.5 times the other, but it didn't deliver a better outcome. Only by understanding the optimal outcome groups can these discoveries be made. More importantly, discoveries such as these are built off of Mercy's data, meaning that Mercy's specific approach to healthcare is taken into account for the development of those pathways. not other hospitals with different approaches, such as academic, teaching, or research. While this clinical pathways approach is just beginning to pay dividends with Mercy and others, they are but a single example of how machine intelligence will transform healthcare. From readmissions to denial, to comparative effectiveness and population health management, the most difficult, persistent, and complex problems in healthcare will resolve themselves through data. Machine intelligence technologies will separate science from marketing, truth from claim, and fact from fiction. You already have the answers. They just lie hidden in your data. Let's find them.
Okay, so you can kind of see this is what we're using to understand and provide the best care. And what we've done, and it's been very compelling with our physicians, is there's no argument. This is our data. It's not, and we've collaborated with many other health systems on care paths and different approaches to care, and that is still important, and we will continue to do that. But it's irrefutable when it comes inside, and we can actually reference individual physicians or patients if necessary to get down to what made this different, what's different in one community or with one physician, and what can we learn. So it's increased the amount of communication in the appropriate way, and even the care paths that we developed manually by getting physicians around the table and putting together those care paths are now being repopulated into this tool so that we can find out is there additional enhancements that will take place. In addition to that, as changes are made on the fly every day, it's capturing this information and continuing to, in a machine learning type of way, inform us in care paths. There's a new technology out there, and it's changing, and it's actually performing better than what we did before. So this is ultimately leading us to comparative effectiveness research, not in the big scale, but in the real scale that we live in on a day-to-day basis. What we believe is if a product has a premium claim, we don't mind paying a premium for it if that is actually leading to a premium outcome. But I don't want to pay a premium for a product that is a part of a wash of all the different variables that go on in care, and I can't point directly to that particular protocol, product, or whatever in providing a premium outcome. If it doesn't, I don't want to pay for it. So that's just, it provides greater insight to us. Let's shift gears a little bit. So if that helps us understand and provide the best care, the next piece is around the operating paths. Let's do so with the least amount of resources. And so we wanted a system that could give us real-time updates and understand all the variables very similar to care paths. The same things are going on in our operations. We have support personnel all over the hospital. We have wheelchairs, we have pumps, we have all these different types of things that are going on. What if we could find a system that understood where things were, what the status of it was, and then relatively using the machine to calculate who needs to be dispatched to help? Wouldn't that be a good thing for us? So we collaborated with a firm to enhance a system that they already had in place, but really to develop a care traffic control system that from a central location we can monitor and modify behavior or send instructions to various locations so that we could optimize the care that we provide. In that, this is an example that we found was highly effective. We're able to show in real time or on a batch basis, depending on how we want to dial it out. In this particular case, it shows the number of tests ordered by each individual physician, and I've disguised the names of the doctors, but in our world, we actually show them exactly how they're doing compared to other doctors. This happens to be deployed in one of our emergency departments that was severely struggling, and so all of a sudden, this information ends up telling you where you're relative to your other peers in that particular area. And I will tell you, just showing that information that way has led to tremendous outcomes. You see the go live point here on this graph, and since the go live point, we've got a 40% reduction in specific lab tests. And what it basically did, once again, it created that discussion of why you're running that test. Well, I've always run that test. That's just what I do. And yet, when they begin to collaborate with each other, say, you know what, in these certain conditions, I don't think that's necessary. And the group is coming together and I guess practicing less defensive care in this particular ED without any negative impacts from a quality perspective. It's saving us substantially. Now, we also have to be careful. In almost every one of these situations, it may save you money, but depending on your reimbursement rate, you actually may lose some reimbursement on that. Our fundamental belief is we've got to do the right thing, and that means take cost out, take unnecessary testing out or whatever that may be, and it will create something good on the other side. In this particular case, it created capacity, and creating capacity was a big issue for us because we also had a significant left without treatment being complete. That kind of leads us to the next one. Left without being seen or left without treatment complete. Once again, we were at just completely unacceptable levels, up at 6.3%. And since deployment, you can see just a rapid de-escalation or reduction associated with left without treatment complete. So once again, this is helping us operationally, interface clinically, and actually deliver on better outcomes. So next up, what I'll do is we'll go into the video of this particular organization, which is Analytics MD, and they've helped us develop a product that's right now in the final justification stages at Mercy.
ER is literally the front door of the hospital. Across the Mercy system, across 35 hospitals, 60 to 70% of our inpatients access the hospital through the ER.
Well, emergency care is so unpredictable, but it is our front door, and this is where patients first experience us. It's so important to give a really good experience in the emergency department.
An issue with the emergency department, we tend to just kind of move from one crisis to another based on whatever comes through the door.
In the ER, we've partnered with Mercy to improve patient flow and reduce costs. Our platform not only statistically identifies key opportunity, but gives operational pathways by which they can be acted upon. Let's start in the ER for an example of flow. Your ER can vary based on a whole host of variables, which include things like staffing, capacity, and even external factors like flu trends, weather, and whether there's a sporting event in the area.
While each of these decisions, coming from millions of data points, machine learning algorithms, may involve a lot of complexity, our systems abstract all that complexity, and to the end user comes a simple, plain English message about what actions we are recommending them to take.
Now when ED charge nurse gets a simple notification, we recommend opening surge rooms in 3 hours from now to avoid patients waiting an extended period of time. She's now able to talk to her staff and open this capacity, thereby preventing the problem from even happening in the first place. Behind the scenes, we're applying some of the latest technology in machine learning and artificial intelligence to connect the dots and adjust in real time.
Every specialty has to become more efficient. We have to be more efficient with patients in the hospital. And proactive data helps us become more efficient in moving patients through the process in the ER.
So what's the impact of all this? Our partners have seen an increase in capacity creation, reduced left without being seen rates, and as a result, improved patient satisfaction. In fact, one of our Mercy partners has seen a 30% reduction in left without being seen rates since we've deployed.
We just talked about how the system proactively lets you know when a decision needs to be made. But sometimes you may still want to understand why these bottlenecks in patient flow might happen. We apply the same statistics retrospectively and in the moment to help you understand that. Here's an example of our root cause tool. Our system first starts by statistically monitoring the key metrics you are interested in. For example, here it's notifying us that the discharged patient length of stay in the emergency room is unusual. By seeing this email and by realizing that, you can click here and very quickly start to understand what may have caused that. So for example, here is discharged patient length of stay day by day in the emergency room. Not only can you see how your emergency room did that day, but also in the background, what the system expected based on how sick were people who were coming to the emergency room, how many patients came in, how many ambulances came in. And by piecing all that together, we're able to draw your attention quickly towards the days where your processes may have had bottlenecks and may not have performed to their best. Not only that, we have patented root cause algorithms that can then help pinpoint where you should look next. So if you click here and ask the system to explain why, it'll run many complex pattern recognitions in the background and identify what is unusual that may have caused this bottleneck. For example, on this day, we saw that most of the delays were happening between 8 a.m. to 2 p.m., so early in the morning. We saw there were a few doctors whose patients took a lot longer than expected. And most importantly, our process from when the labs are received
to when the disposition decision is made was slower by almost 45 minutes. And this 45-minute delay that's happening patient by patient balloons up over time to cause a delay in the discharged patient length of stay, leading to very long wait times and perhaps even poorer care for a lot of the patients coming to our emergency rooms.
We're all creatures of habit, and physicians and nurses are the same. We get used to ordering tests. Some of those tests are ones that we realize we shouldn't order, but we still kind of out of habit order those. If a specialty is not attuned to looking at ways of decreasing their cost in medicine, they're not really going to do well in the healthcare economy.
Our software analyzes millions of encounters to detect unusual patterns of test ordering between physicians in the emergency room. So, for example, by looking at patients with abdominal pain of similar age groups and types, the system detects where there is high variation in ordering patterns. For example, by looking at this graphic here, you can see where there are horizontal lines which represent a wide variety of tests being ordered for similar patients that are perhaps deviations from the standard of care.
So in an effort to try to change a habit, we provide constant feedback in the form of weekly emails, again from Analytics MD, that shows each provider's utilization of those tests, how they rank in that utilization among their peers. So this is a way to, they're very quick, easy to understand emails in the span of 10 seconds. You can look at those every week and understand your utilization and track your own utilization, and that's been a really powerful feedback loop.
The 40% reduction we've seen in these tests alone results in an annualized cost impact of $15 million across Mercy. And that's just these diagnostics. Imagine if the same technology was applied to other forms of ordering in the ED.
So you can see in this particular case, by taking information in a real-time basis and then bringing it forward to the people who can actually act on it when necessary, is really starting to challenge what we've done in the past. And once again, the information that's being shared, it's not being shared to point fingers at anybody. It's just sharing the truth, and then through collaboration and conversations, people are making different decisions. So to us, this is exactly where we need to head in the future. So you've kind of seen most of the examples I've shown have been really more acute focused, but also we personally believe that once again, as we get into risk-based agreements, and the future is going to be outside of the four walls of the hospital and clinic in the future potentially. They'll certainly always be the key anchors of our industry, but Mercy has challenged ourselves to think a little bit differently about this. So we created a virtual care center, but before we even get there, we believe that any type of future solution has got to be really healthcare everywhere. So we have to focus along the entire continuum and start managing along that in a much better way. We also believe the venues of care are going to be something that we have to take into consideration. Yes, the majority of the time we're going to spend the majority of our dollars in the big places like the hospitals, but more and more care will migrate into the homes where honestly people can convalesce much better, they're more comfortable, and it's a better place in our belief. Finally, the mode. You know, the mode of care, there's always going to be local health care, but you also see the tertiary care centers, the regional centers to where people are transferred in. But once again, I think we're going to see more and more migrate to the virtual world in the future. Reimbursement's not caught up with that right now, but infrastructure is being built and programs are being placed out there that are going to change our industry. I mentioned a little bit about this. I'm going to show you kind of a closeout video here and around an integrated continuum of care. If we take this information that we're looking at in our acute care settings in our clinics and apply it here to where individuals with wearable devices that are monitoring their vitals and things like that are then processed, very similar to what we saw in that very first video. We're bringing that back to us in a way that we can respond on any outliers and then intercede and then change the pattern of the transaction many times before a patient even knows that they're having a situation. So what I'm about to show you is a video of the person's not an actress. She's actually a patient of Mercy, but a lot of this is it's not her. Not everything here is her personal experience. I'll tell you that, but I think it's a compelling display of what our future may be in. Let me go ahead and get that started.
At my age, you don't get many phone calls after 10 p.m.
And as a mom with a married daughter in New York City, when I reach for that phone, I'm thinking, something's wrong. Well, as it turned out, something was wrong. Not with Alice. Something was wrong with me. I have type 2 diabetes, and I live alone. So Alice does as much worrying about me as I do about her. But she made arrangements with my doctor at Mercy to wear this little bracelet that monitors my blood sugar and a few other things. I never know what. It tests my blood sugar several times a day and magically sends the results right to Dr. Campbell's nurse. Well, apparently they didn't like the number they got that night. And so the nurse actually called me just to see how I was feeling. She told me my blood sugar was going up, and so was my temperature. I told her I hadn't called the doctor yet, but I did have a rash on my leg, and I just thought it was poison ivy from being in the garden. There wasn't much of it, but it did hurt. And so the nurse asked if we could use my iPad so she could actually see it. When she saw it, she connected me to a Mercy doctor named Dr. Samari, and he thought it might be something called cellulitis and that I should get it checked out in the ER. Goodness, the last time I drove to the hospital at night, it was behind the ambulance that my husband was in. It's a moment that you just feel truly alone. Dr. Samari told me he was calling ahead to the emergency room to let them know I was on my way. And the nurse, Emily, said she was going to text Alice and my friend Donna so they would know what was going on. So I wasn't so alone after all. Dr. Samari was true to his word. When I got to the desk in the ER that night, they knew exactly who I was and why I was there. It wasn't anything like the old days where you had to fill out 10 pages of forms and remember everything that ever happened to you. They had it all, including Dr. Campbell's notes from my last checkup and the blood sugar readings from that very night. It really took a lot of pressure off of me. And that was good, because I really was not feeling very well. After I got settled in the exam room, they brought in a little cart with a monitor on it, and I got to see my new friend, Emily, and Dr. Samari. He explained what they would be looking for in the blood work, and that the ER physician would be coming in to see me soon. I was a little nervous lying there, but I had a lovely nurse taking care of me, and Emily popped up a few times on the monitor, too. So, even though I wasn't feeling very well, I certainly felt important. Though I'd only been in the ER about 90 minutes, I had to admit to Alice on the phone that I really wasn't feeling well, actually worse than I had felt at home. She said she had talked to Dr. Samari, and she was going to be flying in on the first flight she could get. The physician in charge of the ER came in and told me that I had something called sepsis, and that it was very severe. He was very kind and told me that I would probably feel worse before I felt better, but that there was a whole team of specialists, both in the hospital and on the other side of the monitors, that handled cases like this at Mercy. I was still surprised they were taking me to the ICU. Suddenly, I was very glad Alice was flying in and Donna was on her way. The next day was a blur. I had a new doctor in the ICU and new nurses too, and a doctor and nurse that checked on me from a monitor in my room. It took Alice a whole day to get into town, and then by the time she got to the hospital, all I wanted to do was just sleep. I'd never been that kind of sick before. It was almost as though you were too sick to be worried about how sick you are. By the time I was ready to move upstairs to a regular room, I was much more alert, and I even had a real conversation with my daughter, and it became clearer how much effort those doctors and nurses had gone to for me. The team that took care of me in the ICU were there when the new team came to take me to my room. I was too emotional to say much, but Alice, thankfully, was able to tell them how wonderful they were and how grateful I was. The VIP treatment continued for another couple of days. A different doctor and nurse were in charge of keeping an eye on me from the monitor, and the team on the floor took care of me and kept Dr. Campbell informed how I was doing. A sister of mercy came by to see me in my room and offered to pray with me. She thanked God for the mercy bracelet, which had sounded the warning that told us there was something wrong, and for Emily, who called me at 10:30 at night, and for the staff in the ER who found the sepsis, and for everyone else. She told me that God had been watching over me, and she's right. When I was discharged, my nurse explained to me that Dr. Campbell had ordered that I be monitored at home to make sure that I continued to do well. Donna drove me to see Dr. Campbell about a week later, and he explained to me that though I was healthy, a stay in the ICU can sometimes make you more susceptible to certain problems afterwards, so they were going to keep a close eye on me. He also sent me home with a little lab kit that I could use in case something came up and his office was closed. The monitoring would help catch any problems quickly, though, and my nurse would continue to check with me at home. That really reassured me, and Alice, too. The last thing I want is for her to be worried about me every day. She needs to live her life. I actually asked the Mercy chaplain who followed up with me to pray about that I wouldn't be a burden to Alice. I was feeling more and more like myself every day, but about a month after I got out of the hospital, I woke up one morning not feeling well, and I thought, oh no, not again. Dr. Campbell's office had me use my lab kit, and together we figured out that I had a urinary tract infection. No fun, but not as bad as sepsis. And he was able to pull up on his iPad Alice from her desk at work and explain to her that she didn't have to jump on a plane. I'll be fine. Mercy even brought my antibiotic for my UTI to me at home since I wasn't feeling well. By that evening, I was already feeling better. Getting sepsis was scary, but I've lived long enough to know that the scary moments of life usually turn out to be the most important ones. I was scared giving birth to Alice, but she's the biggest gift of my life. And I was scared saying goodbye to my husband, but I could feel God was with me. And sepsis was no different. It showed me that I have so much company. Nurses that know what's happening before I do. Doctors that know just what to do when I'm sick. Even people to listen and pray with me. They're all working together to help me stay healthy. I just get excited for what they'll be able to do next and the difference it will make for my daughter and her first baby due at the end of this year. I just wish they could come home and get the same great care I do. Thanks to Mercy, I'm not going to miss that baby or anything else.
Okay, so forgive the commercials, but honestly, I think that is something that we use internally to educate our own folks and those on the outside. And at least for me, it helps sum up pulling information together applying it to an actual patient situation at all levels of the continuum is truly where we begin to change the way the industry works today. Instead of silos, it's continuum. And it's all informed by information, both clinically as well as operationally, and ultimately financially as well. So as we look at it, for the healthcare industry, using this appropriately will tell us how we perform, the descriptive side of it. It'll also tell us what should happen, the predictive side, and ultimately get to the prescriptive side of what we should do. And I believe that's where we've got to use information to help us make great choices in the future. As we look at supply chain, it's things like what we buy, when we buy it, how much, and then also as we serve in supply chain. I think supply chain's role is going to continue to grow as operational, transactional leaders inside of hospitals and outside of hospitals in the future. And ultimately, it gets to being effective and being efficient. So as we look at effectiveness in supply chains, understand and provide the best service. And then also from the efficiency side to do so with the least amount of resources. So with that, let me just go ahead and close out. And I know we're right at the end of the hour, so if there are any questions, I'll be happy to take it. Or Dennis, why don't you just take it from here and help us out?
Vance, that was fantastic. I will comment. I've seen that patient video before, and it does show how traumatic and personal receiving health care can be. We did have some folks that submitted some questions. Here's one that came in early on the first video. If NASCAR is already using such advanced technology, what, in your opinion, has taken healthcare so long?
Yeah, great question. I think one thing, if you take a look at NASCAR is truly a team. And I think, unfortunately, in healthcare today, we have too many silos, and we don't pull ourselves together in a team-based care. And so that is something I will tell you, information is breaking down those barriers, because information is truth, and when you bring that truth forward, it engages people to ask different types of questions and begin to start to trust and interact with each other in a much, much different way. But I truly believe once again, it was built for team. You live or die as a team in NASCAR. Unfortunately, in healthcare, you do as well, but it's probably just not as well executed.
Now, good answer, Vance. Is a question, can we learn more about the analytics technology stack? I believe that's referring to, the actual systems and machines.
Yeah, I'll give you just a little, well, maybe a little bit. I'm not sure that I'll answer this correctly, but bottom line is, across Mercy, we started early with trying our very best to consolidate and standardize on systems. And then even within systems, we have 35 different hospitals. So how do we do this in a very similar exact way? And so we have built information stacks using Epic as our clinical system, Lawson or Infor is our basically our ERP system. Yeah, and so those are the base systems. We have Omnicell for our medication administration systems, things like that. So we brought those things together in a way that now we go out and access it. Now here's the interesting thing, though. I don't think we'll ever have perfectly clean data. And if we're waiting for that, we'll never get started. So that's one of the reasons why we also reached out to some of these advanced analytics companies that can synthesize and fill in the blanks in information that we may not have. Using advanced statistical processes, it's much more credible than our seat of the pants interpretations, but it also, I will tell you, working through this, it has highlighted some areas of weaknesses that we may have had in our data collection in the past. I was surprised that in many cases, where we have all these different forms, so to speak, in Epic that people need to fill out, when you pull the data forward and start looking at it, there's some fields that say an entire community doesn't even fill that field in, where others they do. And so then it all of a sudden challenges us, well, we either need to stop doing it everywhere or start doing it everywhere, but this piecemeal is a big issue for us. And those are going to be things that when you get into advanced analytics, you start finding the weaknesses that you have, and that'll slow you down. And you need to almost build that into your timeline as you start to investigate this. Almost everybody I've shown these to just gets all excited, but there's a lot of hard work in the preparation getting to this, and you just need to prepare everybody. There's a bumpy road even when you start.
Yeah. Vance, we got a number of questions around, how did this all get started? And here's one that's a little more specific. Can you describe what an ideal team would look like to take advantage of the data, or would this be a committee-driven approach? Yeah,
I tell you how we do it. And once again, it works for us. but we take a clinical, operational, financial, and technical approach. So I think and this kind of gets back to that, what we ultimately need on the delivery of care also needs to be put together in the design of the delivery of care. So much of what we do from a clinical nature, we have many doctors that are working shoulder to shoulder with us that have a passion around data being able to inform us in the future. Operationally, there's not a person who comes to work every day in an operational role at Mercy that doesn't want to do a great job. We just need the information of what we need to do so that it can help direct us to do it. So, there's that alignment. Financially, we can't afford to do everything. So everything, we need to make sure that we have good information, that it's credible, that when we go out and we say we're actually improving, is it actually hitting the P&L? So there's a financial element. And then the technical aspect. Even though we may have all those things we want to do, it's the matter of can we do. And in that particular case, have we built our architecture to be able to support this? Do we have the capabilities of archiving, storing, and retrieving information the way we need to? That's a big deal to us. So those 4 elements, I think, are key when you pull the teams together to be able to execute it. And I will tell you, all of those tend to be in their own individual silos. It'll be hard to be effective until you can kind of merge those silos into at least an interactive team.
Great. Vance, just a couple more questions, and then we'll conclude. One of our attendees asked, is Mercy building their own analytics practice, or is the plan to outsource those activities?
I would tell you everything we do is a make-buyer-partner equation. We believe that we have to have internal expertise, and this is kind of a tricky part. There's a great book that Curtis Dudley, I think many of you may know Curtis, shared with me, called Business IT Fusion. I read it a couple years ago, and it talks about how analytics and IT has to get out of their silo and become more integrated in the business. I completely believe that. At the same time, it can't be so integrated with the business that you don't have standards. So we have this pendulum at Mercy we've been through. So we've made most of the mistakes. We have been completely decentralized and put great people out in the communities or in the specialty councils or whatever you want to, whatever the area. But then you get complete fragmentation of information. We've done it the other way. We've had very centralized, so where we said we're going to have a centralized repository of information with a centralized team. You just ask them any question you want and they'll give it to you. What we found out is they didn't have context. So they would say, well, here's a field that says that must be what they're looking for, run the analysis, hand them the report. Completely failed, because we get it and we go, what idiots, this can't be right. And so we start and have the shadow structure. So here's that balance to where I think you have to have an internal team that is able to be very associated with and even tied directly to the architecture of your systems, but they have to be embedded in the business so they have contextual knowledge, and we call them performance analysts. And they're continually churning data every day, looking for anomalies to then point out to the leaders and context leaders of those, whether they be physicians or financial leaders or operational leaders. And that is where the balance comes in. Now here's the tricky part. And it's, are you going to insource or outsource? I think we're going to do a little both. Where it's contextually important that we know more than anybody else on this, I think we do it. But I've also seen where there is a great deal of advantage, like we saw with Analytics MD and Yazdi, that they have information and talents and access to tools that we just do not. And so I believe it'll be a blending of the two. Contextual knowledge of Mercy, contextual knowledge of healthcare, I believe that is necessary. Knowledge of advanced analytics and the way in which we store and retrieve information, that will probably be outsourced to a large degree.
Good answer. Thank you, Vance. Here's one last one. How do you think the predictive and prescriptive nature of healthcare at the clinical level actually relates to the supply chain?
Yeah, I will say so several different ways. And so let's take a look at it from just a quick example. So when somebody is admitted to the hospital, let's keep it at the acute care setting to begin with. When they're admitted and diagnosed, we have a pretty good idea of when they'll be discharged. Yet, unfortunately, so many times we don't start looking for the transporter or the wheelchair or whatever until there's been an order written and dropped, and then somebody says, oh yeah, we got to go find that and go service them. Now, I know there are some organizations that do it much better than we do, but that's how, unfortunately, we've tended to act. But if I knew a day and a half ahead of time, or even 6 hours ahead of time, what I was going to need, then I could begin to stage products, or I say products, and transport devices and people in a much better way. Same thing, if I have a patient that has a certain condition inside of a particular room, instead of having general supplies in the nurse server or nearby, I could actually build almost a kit that could then be moved into that particular area that would be much more appropriate for that patient's condition, because I've seen this enough times to where I say, I know they're going to need this, this, and this. So it allows us to be much more predictive and almost customized from a service perspective. And then we just have to balance, does doing so actually, is it advantageous from a labor perspective? Are we restocking things more than we would if we just said, hey, we're just going to do a general deployment of supplies and the nurses will make do or whatever. So those are just a couple of areas where I think it will apply. You know, also on the other side is when you look at it in the ambulatory setting, if we're treating, and I think we will treat more and more people in their home, especially the chronically ill, supply chain, I believe, is going to leave the building, so to speak, and transport and servicing people in the home. You saw in the video to where we're making home deliveries of pharmacy, but you will see DME and also monitoring devices and things like that. Once again, if we can predict what's going to happen and then be able to understand what we may need on our vehicle in that day, then all of a sudden we may be out on the streets, and so somebody has a condition that they need something, we can swing by and be highly effective and efficient in servicing those patients actually in their home.
Vance, this has been fantastic. It's a great amount of participation from everyone. I know we've gone about 11 minutes over, but Vance, I want to thank you for putting this together, for sharing this with us, and for the passion that you display for this topic. I think we'll adjourn now, but I will remind folks that you'll receive a automatic post-webinar survey from the GoToWebinar system, and we'd like you to make sure you fill that out if you can. Vance, this has been fantastic, and again, I want to thank you and thank everyone for attending today, and I hope everybody has a great rest of the day.
Thanks a bunch. We'll see you later.
Thank you much. Bye-bye now.